This is our schedule for today. We have a lot to cover, so we'll go ahead and get started with the research problem. Cancer patients and survivors are faced with various physical, psychological, and financial challenges. It's really important to support the well-being of cancer patients and survivors throughout the entire continuum of care, from initial diagnosis to post-treatment. And given the physical, psychological, and financial challenges, we suspect this population may be at risk for food insecurity. However, this has not yet been well studied. This is significant because the consequences of food insecurity may be severe for this population, especially considering this population's complex medical and nutritional needs. Food insecurity may lead to disease progression, suboptimal clinical outcomes, as well as increased utilization of healthcare services such as emergency departments, visits, and overnight hospitalizations. So essentially, the purpose of this dissertation was to gain a deeper understanding of food insecurity among cancer patients and survivors by examining the prevalence and correlates of food insecurity, adverse healthcare-related outcomes, and identifying factors that may buffer risk. These three research questions guided the study. So essentially, I built upon existing theory and research, and the hope is that the findings from this research, as well as future related research, will translate into actionable steps to impact both practice and policy, especially from a standpoint of screening and intervention development. So, what is food insecurity? While I have an empty plate here, food insecurity is actually much more complex than simply not having enough food on your plate. The formal definition is included here, but essentially what food insecurity means is that individuals who are food insecure worry about being able to obtain enough food to meet the nutritional needs of all household members due to insufficient resources or money. Food insecurity is typically episodic, meaning it does not last every single day of the year, but rather occurs over periodic episodes lasting several days to several weeks. Also, it's important to realize that food insecurity really differs from hunger. They're closely related, but they are different. So food insecurity is more of a household level economic and social condition related to limited access to food, whereas hunger is an individual level physiological condition. Of course, food insecurity can lead to hunger. However, hunger can be caused by many other reasons, such as not eating breakfast this morning. So, how is food insecurity measured? There are different measurement scales. The main differences in these scales are the look-back reference period, as well as their length. Of those scales used in national surveys, the look-back period is either 30 days or 12 months. And those scales vary in length from 6 to 18 items, depending on whether the survey that's used, as well as whether children are in the home. There are different categories of food security. For most reporting purposes, high and marginal food security is considered food secure, whereas low and very low food security is considered food insecure. So what do these different categories really mean? Well, individuals who are highly food secure, they don't have to worry about obtaining food to meet those nutritional needs of their household members. Individuals who are marginal food secure, they have some worry, maybe one or two problems, may express anxiety about that shortage of food, but there's little to no indication that they alter their eating patterns or their quantity of intake of food. Now, individuals who have low food security, they do indicate problems with accessing and obtaining food, and there's indication that they alter their eating habits and patterns, meaning that they may alter the variety of food or the quality of food, but again, there's little to no indication that they actually reduce their food intake. And finally, individuals who are very low food secure, they do both. They alter their eating patterns and they also reduce the quantity and the amount of food they consume. So now that I've talked about food insecurity, we're going to transition for just a minute to our target population, cancer patients and survivors. Unfortunately, because there have been significant advancements in the diagnosis and treatment of cancer, cancer is now considered a chronic condition. There's a growing number of individuals living in the US with cancer. Nearly 5% of the US population has been diagnosed with cancer at some point in their lifetime. It's expected about 1.9 million individuals will be diagnosed in 2022 with cancer. But the good news is, death rates are declining, survival rates are increasing, and the 5-year relative survival rate now is at 67.7%. However, despite these advancements, cancer patients face physical challenges such as fatigue, decreased endurance, neuropathy, psychological challenges such as depression and anxiety, as well as financial challenges. For the purpose of today's presentation, we're going to focus on the financial challenges and how they relate to food insecurity. Essentially, cancer is one of the most expensive chronic conditions to treat. Cancer patients are faced with high financial burden, decreased income, as well as increased risk of bankruptcy. Breaking that down just a bit more, from that high financial burden standpoint, even if cancer patients are insured, they may be responsible for multiple high out-of-pocket costs. Some of you have previously heard this example. But for a cancer patient who is on Medicare D, when they're prescribed a high-tier oral chemotherapy drug, such as Revlimid, if they live in a household of 2 individuals and their income exceeds $91,500, they will likely not qualify for copay assistance. What that means is over the course of 12 months, that cancer patient may be responsible for $10,000 to $14,000 of out-of-pocket costs for that prescription medication alone. It's a lot to swallow when you're an older adult on limited income. Also, cancer patients regularly face decreased income. About 40 to 85% of cancer patients stop working at some point throughout the course of their treatment. And those earnings tend to drop for a 5-year period due to lingering side effects and missed opportunity cost. Also, this population has an increased risk of bankruptcy, nearly 2.5 times more likely than individuals without a cancer diagnosis. So, as you can see, and you suspect, cancer patients are faced with multiple competing demands, missed opportunity costs due to limitations with advancement in career, reduced income, indirect medical costs such as those transportation costs to and from treatment, parking costs, wigs, cosmetic items, lymphedema, and medical equipment not regularly covered by insurance. They also have direct medical costs such as those insurance premiums, deductibles, copays, as well as those prescription costs we just discussed. And on top of that, they have daily living expenses, housing costs, utility costs, childcare costs, and also food expenditures. So this can become quite a balancing act to manage these multiple competing demands, far more difficult than the game of Jenga. So given these multiple competing demands, we suspect cancer patients and survivors are at risk of food insecurity. They really may be forced to make these trade-offs between food, medical care, and other basic needs. Unfortunately, there remains a gap in knowledge in that there are few empirical studies that have examined food insecurity among the cancer patient and survivor population. Over the course of the next few slides, I'm going to talk about what we know among the general or comparable populations, and then also give a brief overview of what we know among the cancer patient and survivor population in terms of food insecurity. So in 2020, which is the most recent estimates of food insecurity, about 10.5% of US households were food insecure. Among cancer patients and survivors, the literature suggests that the range of food insecurity prevalence is 8.36% to 84%. I want to acknowledge this is a really wide range, and there's a lot of different reasons for this. The studies really varied in sample size. Some used nationally representative data sets, where others used smaller convenience-based samples. Some recruited from cancer centers as well as food pantries. And in some of those studies, there was a high proportion of low-income patients as well as minorities, and data shows that low-income and minority patients have higher food insecurity rates. These studies also varied in terms of inclusion and exclusion criteria, the measurement scales used, and design. So there's some lack of generalizability and comparability among studies. Also, there are numerous adverse outcomes of food insecurity. Many of them are highlighted here. For the purpose of today's presentation, I'm only going to focus on those most relevant to our study. So food insecurity may lead to the onset of new physical and psychological conditions such as diabetes, cardiovascular disease, as well as anxiety and depression. It may also lead to increased healthcare service utilization. Berkowitz found that individuals who were food insecure had higher number of emergency department visits, overnight hospitalizations, longer lengths of stay, as well as more outpatient visits. However, this study suggests that individuals who are food insecure have fragmented or lack of coordinated care, as they are less likely to report a usual source of health care. And closely related to that is increased healthcare expenditures. While they may either have these increased ED visits or they may even postpone medical care, the downstream effect is eventually increased healthcare costs. Berkowitz found that food insecure adults were nearly $2,000 higher medical expenditures than food secure adults, resulting in about $51 billion in excess costs. And finally, food insecurity is associated with decreased treatment adherence in both general medical care as well as prescription adherence. So why does this matter for cancer patients? Well, adequate nutrition is critical for cancer patient disease management throughout the entire continuum of care. Inadequate nutrition can really lead to complications with immunosuppression, healing from surgery, management of those gastrointestinal side effects. It can really compromise disease management. For example, if the proper food is not used to combat those gastrointestinal side effects of chemotherapy, some patients may become less adherent and even walk away from their treatment. So this may really lead to suboptimal clinical outcomes. Some cancer patients who are food insecure have been shown to reduce both food and medication intake as a result of food insecurity. A study by Zafar found that nearly 55% of cancer patients who were food insecure reported not taking a prescription medication, in comparison to about 12.8% who were food secure. And then also, food can really increase side effect profile and also absorption rates. And one example, some of you have heard this already, is that the medication known as Tasigna, which is used to treat leukemia, when it's taken with high food and high fat consumption, it can reduce the absorption of that medication by nearly 50%. This has real clinical implications, and it's really relevant to the food insecure population because individuals who are food insecure may opt for those higher fat foods because typically they're cheaper. Also, it's been shown that food insecure cancer patients are more likely to postpone medical care. A study by McDougall found that persistently food insecure cancer patients and survivors were nearly 9 times more likely to make changes, delay, or forgo their non-prescription based medical care. And when we look at prescription usage among that population, they were nearly 3 times more likely to make changes, delay, or forgo prescriptions. And finally, as a downstream effect, while medical care may be initially postponed, it may eventually lead to increased healthcare utilization and expenditures. There are different determinants of food insecurity. Some factors may increase risk, as well as some factors may reduce risk. For the purpose of this study, giving our research questions, we're going to specifically highlight those factors that may buffer risk. I'm focusing on buffers from a micro, meso, and macro level standpoint. Research has suggested, some of that done by Jane, that availability of assets rather than income may be more effective in protecting against food insecurity, especially when those negative income shocks potentially related to changes in employment, disability occur. Also, social capital from a meso standpoint. And what I mean by social capital are those relationships across networks and groups such as churches, families, and neighborhoods that have both social and material benefits. High social capital may really reduce the risk of food insecurity. So individuals who have high social capital may be more likely to ask for additional assistance when faced with multiple competing demands. And finally, at the macro level, participation in safety net programs has been associated with decreased food insecurity. There are some conflicting research, and we'll dig into that in a bit. Health insurance and participation in food assistance programs may serve as buffers to food insecurity. So essentially, the study was guided by 2 theoretical frameworks. The Seligman and Schillinger model shows the cyclic relationship between food insecurity and cancer. Essentially, Seligman and Schillinger posit that individuals who are food insecure have multiple competing demands. This can lead to impaired disease management. This may lead to the onset of additional chronic conditions, early disease progression, and either directly or indirectly lead to increased healthcare service utilization and cost. On the right side is the Heflin, Corcoran, and Seifert framework. They posit that 3 mechanisms contribute to the onset of food insecurity. These mechanisms include resource availability, competing demands, and coping strategies. Breaking that down just a bit more, resource availability influences food purchase and consumption. If resource availability is limited and there's constrained resources, individuals may be faced with multiple competing demands and may be forced to make trade-offs between food, medical care, and basic needs. However, in some circumstances, even when there's limited resource availability and competing demands, some individuals remain food secure due to coping strategies. So this is the conceptual model guiding the proposed study based upon those theoretical frameworks that I just discussed. Kind of focusing on that just a little bit more. So individuals with cancer may have constrained resource availability due to indirect and direct medical costs, as well as missed opportunity costs. This may lead to competing demands, and they may be forced to make trade-offs between food, medical care, and other basic needs. As a result, this could lead to food insecurity. However, what we're most focused on in this scenario is that coping strategies. We wanted to look at to see if the availability of assets, participation in social programs, or social capital may reduce that risk, and we examined that in AIM 3. And as you can see, this portion of the conceptual model is guided by Heflin, Corcoran, and Seifert. And then we also suspect, based upon existing research in the Seligman and Schillinger model, is that household food insecurity, due to those competing demands and impaired self-disease management, may lead to the onset of additional physical and psychological conditions, non-adherence in terms of medical care and prescription usage, as well as increased healthcare service utilization. So now we move on to methods. I'm going to give a very general overview from a standpoint of data set, sample, and analyses, and then I review the more specific methods as I go through each aim. So the data set used was the 2015 to 2018 National Health Interview Survey. This is a continuous, nationally representative, cross-sectional survey. It was selected because it had variables that were relevant to my study aims. It included socio-demographic variables, variables that captured cancer status and food security status, as well as variables that captured healthcare utilization and adherence. Data from 2015 to 2018 was used to ensure I had a large enough sample size, considering the power in that as well. Data beyond 2019 was not used for 2 reasons. The survey was redesigned in 2019, and it's not recommended that you use that data when there's the redesign. Also, considering the potential bias and impact of the COVID-19 pandemic, I did not want to use data beyond 2019. The sample consisted of individuals who endorsed a previous diagnosis of cancer. I had a primary sample as well as a subsample. So that primary sample consisted of all adults with a lifetime history of cancer, regardless of the amount of time that had elapsed since the diagnosis. That sample was comprised of 12,984 individuals. The subsample was a much smaller sample composed of 1,806 individuals and was newly diagnosed cancer survivors, defined as a diagnosis within 1 year or less since time of survey. The main purpose of looking at these primary and subsample is to see if there were differences in terms of prevalence, outcomes, and factors that may buffer risk. All of my outcome variables and dependent variables were categorical, so I employed logistic regression. Aim 1 was, the objective was to identify the prevalence and correlates of food insecurity among the target population. The dependent variable was household food security status. The NHIS captures household food security status by asking 10 questions. The reference look-back period is 30 days. They asked questions that captured behaviors related to obtaining food. You can see those different behaviors highlighted in yellow. If individuals endorsed no on the first 3 questions, no further questions were asked. Affirmative responses was coded as a 1, and a sum score was generated ranging in scores of 0 to 10. For the purpose of this study, scores of 0 to 2 were considered food secure, while scores of 3 to 10 were considered food insecure. This is based upon other reporting structures as well as existing research. In addition to household food security status, various socio-demographic variables were included in the analyses as well, and this is based upon existing research. We used cross-tabulations to report the prevalence of food insecurity for both the primary and subsample, and also reported prevalence of food insecurity by cancer type. Descriptive statistics were reported for socio-demographic characteristics, and again, logistic regression was used. So what did my study show for AIM-1? On this slide here, you'll see the descriptive statistics for the primary sample. Again, that entire sample consisted of 12,984 individuals. Among this sample, the majority were female, older, Caucasian, non-Hispanic, not married, had no minor children in the home, some college. Slightly more than 50% had incomes that were 399% or below the federal poverty level, and the majority were from the South. Among this primary sample, about 8% were food insecure. Among the individuals with cancer who were food insecure, the majority were female, younger, Caucasian, non-Hispanic, not married, had no minor children in the home, some college. About 77% had household incomes that were 200% or less than the federal poverty level, and the majority were from the South. We also looked at food insecurity prevalence by cancer type. The highest prevalence of food insecurity was found among those with prostate cancer, closely followed by cervical cancer and breast cancer. However, as you can see, the food insecurity range by cancer type was very wide. In a few slides, we will unpack potential reasons why. Regression analysis was also run for the primary sample. Essentially, what this showed is that being male, older, married, and having household incomes that were 200% or above the federal poverty level significantly reduced the odds of food insecurity, whereas race, being a Black, African American, or of another minority race, significantly increased the odds of food insecurity, as did Hispanic ethnicity. Descriptive statistics were also reported for the subsample. As a reminder, the subsample consisted of 1,806 individuals. Among that sample, the majority were female, older, Caucasian, non-Hispanic, not married, had no minor children in the home, some college, had incomes that were 399% or less below the federal poverty level, and were from the South. One of the main takeaways from this slide is that in terms of composition, both the primary sample and the subsample were pretty similar. Among this sample, there were slightly higher rates of food insecurity at a rate about 9.5%. This is not surprising. I'll explain why in just a bit. Among the food insecure cancer patients and survivors, the majority were female, younger, Caucasian, non-Hispanic. They were pretty well balanced in terms of marital status, had no minor children in the home, had some college. Nearly 80% of that group had incomes that were 200% or lower than the federal poverty level, and the majority were from the South. Regression analyses were also run for the subsample. Essentially what this analysis showed is that being older and having household incomes that were 200% or above the federal poverty level significantly decreased the odds of food insecurity, while being Hispanic race significantly increased the odds. One of the main differences between the primary sample and the subsample findings is that male gender was no longer a significant predictor of food insecurity, nor was race. AIM-2 investigated the risk of adverse healthcare related outcomes among individuals who were food insecure. We hypothesized that individuals who were food insecure would have higher odds of psychological distress at a level indicative of severe mental illness, increased healthcare utilization in terms of emergency department visits and overnight hospitalizations, and then also decreased treatment adherence by not getting needed medical care, delaying care, skipping or taking less medication than their food secure counterparts. In addition to food security status and the covariates examined in AIM-1, I looked at included various variables in different analyses that captured adverse outcomes. These variables were selected for different reasons. One being is that existing research suggested that these adverse outcomes are associated with food insecurity. And then from a very practical standpoint, from my experience in healthcare, anytime you want to implement a new policy or a practice, it's important to have buy-in from individuals who are involved at all levels of that process, from those individuals administering the screening to those following up, to the providers that may be informed of the results, and to the administrators who may be making decisions about resource allocations. And so that requires that there's an understanding of the why behind the process that's really relevant to each of those different groups of individuals. And all the adverse outcomes I selected have a why that's relevant to those different groups of individuals. From a mental illness standpoint, we know that mental illness leads to increased mortality, cardiovascular events, potentially increased healthcare utilization. And so that's really relevant to clinicians as well as patients themselves and potentially administrators. In terms of utilization, we looked at emergency department visits and overnight hospitalizations. In healthcare, this is of significant focus right now. Due to reimbursement and quality standards, administrators are really interested in reducing unnecessary ED visits and overnight hospitalizations. So this is very relevant to our administrators and likely clinicians as well. And then finally, from our adherence variables, we looked at different ones related to medical care as well as prescription usage. These are really relevant to our clinicians, meaning our providers and our nurses, because it has real, true clinical implications such as suboptimal outcomes. And then, of course, this is relevant to patients themselves. So we used cross-tabulations to report the prevalence of the sample that experienced the various adverse outcomes, and logistic regression analyses were used. This slide here shows the prevalence of adverse outcomes by different groups. I'm going to draw your attention to the food insecure sample here. As you can see, that among the food insecure sample, each of these adverse outcomes were endorsed by greater than 20% of that sample, with nearly 50% of the food insecure individuals endorsing emergency department visits. The main takeaway from this slide is that when we look at the percent of adverse outcomes that were endorsed by the food insecure population in comparison to the food secure population, there was much higher rates of endorsement among the food insecure population. As you can see here, similar trends were observed among the subsample. Higher endorsement among the food insecure population in comparison to the food secure population. We also did multivariate regression analyses predicting these adverse outcomes. Essentially what this analysis showed is food insecurity significantly increased the odds of experiencing each of these adverse outcomes, with the highest odds being for psychological distress at a level indicative of severe mental illness, followed closely by those adherence outcomes. Our findings were observed for the subsample. Food insecurity significantly increased the odds of experiencing each of these adverse outcomes. Aim 3 examined factors that may reduce food insecurity risk. We hypothesized that the availability of assets, neighborhood social support or social capital, participation in food assistance programs, and being insured, meaning having medical insurance, would reduce the risk of food insecurity among individuals with a history of cancer diagnosis. The food security status was our dependent variable in this analysis. I chose variables that were spanned across the micro, meso, and macro levels. At the micro level, we looked at assets in terms of receipt of interest and dividend income. At the meso level, we looked at social capital in terms of neighborhood social capital. And at the macro level, we looked at participation in social programs such as medical insurance or food assistance programs such as SNAP or food stamp. We used cross-tabulations to report the prevalence of food insecurity based upon endorsement of the determinant, and logistic regression analyses were again employed. So this table here shows the prevalence of food insecurity based upon endorsement of each of the different determinants. We're going to focus on this portion of the table at this point. With the exception of positive endorsement or participation in food assistance program, prevalence of food insecurity was higher among the group that endorsed these different determinants. For example, you can see among the group that endorsed receipt of interest income, the prevalence of food insecurity was 1.24% in comparison to 12.02% of those that indicated that they did not receive interest income. The exception was this. There was a higher prevalence of food insecurity among participants who positively endorsed participation in food assistance programs. While in some ways this may seem counterintuitive, it is actually not, and we will explain some of the potential reasons why in just a bit. Again, the prevalence of food insecurity based upon endorsement status reveals similar results among the subsample. Multivariate regression analyses were also employed. Essentially, in the primary analysis, what this showed is, with the exception of food assistance program participation, each of these different determinants significantly reduced the odds of food insecurity. Similar findings were again observed in our subsample. The main difference being is that medical insurance coverage in this sample was no longer a significant predictor of food insecurity, and we'll review the potential reasons of why in a few slides. So now I synthesize our findings. So what did this study really find, and what does it mean in terms of practice and policy? In AIM-1, we examined our prevalence and correlates of food insecurity. In AIM-2, we looked at the adverse healthcare-related outcomes. And in AIM-3, we identified factors that may buffer risk. The arrow at the bottom is used to signify the interrelatedness of these aims in terms of practical implications for policy and practice, especially in regards to screening and intervention development. So again, in AIM-1, we looked at the prevalence and correlates of food insecurity. Among that primary sample that included all individuals with a lifetime history of cancer, food insecurity prevalence was about 8%. It was slightly higher at 9.5% among those newly diagnosed cancer survivors. It's not surprising that the prevalence rates were slightly higher among that newly diagnosed cancer group. And that's because research suggests that during those initial treatment phases, as well as end-of-life care phases, out-of-pocket costs, as well as time costs from a perspective of missed time away from work, are highest among that initial and end-of-life care phases in comparison to that maintenance phase of treatment. Also, upon initial diagnosis, cancer patients are faced with numerous unanticipated medical and indirect medical costs, as well maybe miss much work and have reduced income. It's likely that initial diagnosis, that wasn't budgeted or accounted for. But for those individuals who are in more of their maintenance phases of cancer treatment, they may have been able to modify, budget, and adjust to that decreased income. So we would suspect that that newly diagnosed cancer patient may have more competing demands and less resources to buffer that risk. Also, it's important to note here, these prevalence rates are lower than national estimates of food insecurity. It was kind of surprising to me. A couple reasons why is the composition of the sample. We'll unpack this just a bit more in the limitations, but generally this population was older adults. And we know that from research that typically there's lower rates of food insecurity among older adults. Also, this population was primarily Caucasians and non-Hispanic, and existing food insecurity estimates at the national level and research shows that food insecurity rates are higher among minorities. There's also much variation in food insecurity prevalence rates based on that type of cancer. A few reasons for that. Those sample sizes varied by cancer type, and also cancer, based upon what the diagnosis is, can really have a different impact on one's ability to work. Some cancers may have higher treatment burden and symptom side effects, and this may lead to decreased income, whereas other cancer diagnoses may not have as much of an impact on ability to work. Another is socio-demographic characteristics that are associated with different cancer diagnoses. What I mean by that is some diagnoses are more likely to affect younger patients than older patients. Also, while we can't fully examine it in this study, some patients in these different disease groups may have had greater access to financial assistance from friends or family or disease-specific programs. And finally, both the primary and sub-analysis revealed that younger age, lower household income, and Hispanic ethnicity significantly increased risk of food insecurity. This is also consistent with existing research. It makes sense from a younger age standpoint. Individuals who are younger age may have more multiple competing demands, potentially student loan debt, childcare, and have accrued less assets due to lower amount of time in the workforce. Also, national estimates, again, indicate that lower household income and Hispanic ethnicity is associated with increased rates of food insecurity. Aim 2 looked at those adverse healthcare related outcomes, and essentially, food insecurity increased the odds of experiencing each of the adverse healthcare outcomes examined. This is supported by existing research in the general population, comparable populations, as well as that limited research in the cancer patient and survivor population. Just two things to point out. From a psychological distress standpoint, a study by Madigan found that food insecure cancer patients had higher PHQ-9 or depression scores than food secure counterparts. And also we already reviewed with medical non-adherence that increased likelihood of delaying, forgoing, or changing both medical care and prescription treatment as reported by McDougall and colleagues. And finally, risk-reducing buffers were examined in Aim 3. In both the primary and sub-analyses, both receipts of assets as well as neighborhood social capital reduced the risk of food insecurity. This again is consistent with existing research, some of that research done by Jean, and also similar research looking at social capital in terms of food insufficiency done by several people in this room as well. One finding I wanted to just unpack a bit was, again, medical insurance significantly reduced food insecurity risk in that primary analysis, but it was no longer significant in that sub-analysis. This may be due to, again, at that newly diagnosed cancer phase, increased competing demands and highest rates of out-of-pocket cost. And so essentially food insecurities, insurance may not have been able to buffer that risk. And finally, participation in food assistance programs increase the odds of food insecurity. This is due to selection bias. Individuals who have trouble accessing food are more likely to enroll in programs such as food stamps and WIC. However, than individuals who do not have those problems. So this study has implications at the macro, meso, and micro levels. Of course, additional research would be needed to really implement all of these implications. But in brief, at the macro level, this may lead eventually to mandates for universal food insecurity screening. Currently, cancer patients are required to be screened for distress at pivotal moments throughout the entire continuum of care, but no comparable screening exists for food insecurity. The screening tool that's used could easily integrate a question about obtaining food. It currently asks about problems with nutrition, but does not specifically look at obtaining food. And hopefully the awareness of food insecurity as well as the adverse effects at the policy level would lead to increased resource allocation for interventions that could decrease food insecurity risk. At the meso level, I look at that from a cancer center perspective. Hopefully this will lead to implementation of food insecurity screening processes. And the awareness of the impact of food insecurity will hopefully lead to comprehensive interventions, such as comprehensive navigation, that not only address food insecurity risk, but also the causes for food insecurity risk and ways to decrease adverse healthcare outcomes. So for example, I think a goal would be is that if someone screens positive for food insecurity, they are then also screened for depression and anxiety, as well as decreased treatment adherence. And then that social worker or navigator would connect them to comprehensive resources. And so essentially, the hope is that this would benefit cancer patients. By having a mechanism to identify food insecurity, hopefully they will have increased access to resources that will decrease both food insecurity and the risk of adverse healthcare outcomes. As with any study, there are limitations. NHIS relies on self-report data, so there's a potential for social desirability bias as well as recall bias. Some individuals may be ashamed to report food insecurity, and recall bias due to memory challenges, a phenomenon known as chemobrain among the cancer patient population, as well as just overwhelming stressors, may lead to inaccurate reports in terms of food security status, cancer status, adverse outcomes. So this subjects the data to under and overestimates. Also, in terms of the measurement tool, NHIS only looked back at the period over 30 days and did not look back at the period of over 12 months. And considering that trajectory with the cancer care and management, that may have implications. And then also that measurement tool only considers the procurement of food based on financial challenges. We know that cancer patients have unique physical challenges, fatigue, decreased endurance, psychological challenges, depression, anxiety, and these challenges really could impact that procurement of food. And so future research should really consider whether measurement tools may need to incorporate questions that evaluate the ability to access food based upon physical and psychological challenges. Of course, this data is cross-sectional, and so that limits our ability to make causal inferences. There's also a wide variation in cancer clinical characteristics. What I mean by that is there are different clinical characteristics that impact patients differently. So cancer type, stage, and treatment can really impact patients in different ways. So a more advanced cancer diagnosis may really have a greater impact on cancer patients than a less advanced diagnosis. And simply the dichotomous measure of cancer status, yes, no, does not capture that wide variation. And so future studies should really consider looking at that variation in food insecurity prevalence and outcomes based on those varying cancer characteristics. There may have also been unobserved factors that were not captured in the analysis due to variables, and these may correlate with or contribute to food insecurity and adverse outcomes. There may also be challenges with temporal ordering. We cannot discern whether food insecurity occurred pre or post-cancer diagnosis, and also we're unable to determine the onset or timing of those adverse outcomes. Finally, in terms of limitations, the availability of variables in the data set, additional variables should be considered. For example, employment was not considered or included in the analyses. This is because the NHIS only looked back at employment from a standpoint of 1 week, and I feel like the reasons that they included to capture employment status just were not relevant to the cancer patient and survivor population. I looked at other studies that used NHIS to examine food insecurity among cancer patients and survivors. They also did not use an employment variable. Additional variables such as evaluating the PHQ-9 and GAD should be considered in models. And this is because while we use the Kessler's distress scale, it reports mental illness from a general standpoint, but it does not specifically look at depression and anxiety. And GAD-7 and PHQ-9 really has relevance to clinicians. And so by being able to say that PHQ-9 scores and GAD-7 scores were higher among food insecure cancer patients may have true implications and relevance to those clinicians. PHQ-9s and GADs were not included in this survey, but beginning in 2019 they are. Also, it may be important to incorporate comorbid conditions into the analyses to look at that influence on food insecurity as well, or controlling for them. Study sample. The race and ethnicity was not well balanced. Nearly 90% of that population was Caucasian, higher rates, 95% being non-Hispanic. We know that food insecurity rates are higher among minorities. These rates were comparable. Again, I looked at different studies that use the NHIS focused on cancer patients, and these numbers were comparable. One thought of the reason is that minorities, unfortunately, due to limited access to healthcare, may have underdiagnoses when it comes to cancer. Also, the majority of our sample was older. We know that food insecurity rates tend to be lower among older adults. About 60% of our population, our sample, was over the age of 65. I did look at the SEER data regarding those percentages, and over 65% of cancer patients over the age of 65, or excuse me, 65% of cancer survivors are over the age of 65. So in many ways, that sample is consistent with what's observed from a cancer statistic standpoint. And finally, there may be possible underestimates for reasons other than self-report data. This is a difficult to reach population. Cancer patients have overwhelming stressors and multiple competing demands. They may opt to not participate in national surveys. Similarly, individuals who are food insecure have multiple competing demands and may not opt to not participate. And then if they have both cancer and food insecurity, it may also impact that. Finally, while there are limitations, this was an important step forward in understanding food insecurity among cancer patients and survivors. And there are many opportunities for research. We can start by building on our existing findings. The methods and analyses used in this study can easily be replicated in the use of other data sets, such as the NHANES, and also in use in convenience-based samples, potentially samples recruited from cancer clinics, as well as food pantries. We should further examine food insecurity based on those different clinical and socio-demographic characteristics that I identified and see how rates of food insecurity as well as adverse outcomes vary. We should also look at the influence of food insecurity on other outcomes. Of particular interest may be healthcare expenditures. The Medical Expenditure Panel Survey, which is linked to the NHIS, may be a useful tool in looking at whether healthcare expenditures among cancer patients who were food insecure were significantly higher than cancer patients who were not food insecure. We may also be important to look at whether the influence of food insecurity really affects the management of other diseases. And finally, it would be important to further examine those buffers identified in this study and the influence of other clinic-based interventions. We can also think about future research from a study design standpoint. Investigator design studies and trials may allow for a deeper or more specific analysis of those themes uncovered from this national data set surveys by tailoring questions of specific relevance. Longitudinal surveys may be really meaningful to evaluate the consequences of food insecurity over time. I also think it would be really interesting to look at the consequences of food insecurity of children of cancer patients over time. Trend studies would really be relevant to understand food insecurity over time and the trends in that, specifically looking at changes in food insecurity rates potentially based upon new policy implementations such as the ACA and other future policy implementations. And then qualitative studies may also really be relevant as they can illuminate the lived experiences of food insecurity among this population that simply survey and quantitative data may not be able to fully capture. And finally now, I think one of the most important steps forward in food insecurity research is really developing screening processes. And so there's much opportunity for research in this. As I shared earlier, anytime we implement a new policy in healthcare, it's important to make sure that we evaluate the feasibility and acceptability of new practices. Pilot studies could reveal understanding barriers, systems that need to be put in place, as well as allocation of resources. Quantitative and qualitative approaches can be used to understand the acceptability of screening from different individuals who are involved in that process. I find that there's greatest resistance sometimes in policies and practices if patients, again, providers don't understand the why behind it, and also if they feel like they're screening for something and they don't have adequate resources to refer patients to. So getting a deeper understanding of that acceptability and what's necessary in further education is important. And while universal screening would be that gold standard that we want to aim for, it may not be possible due to financial resources or human resources. Predictive modeling approaches using machine learning may be an opportunity to explore food insecurity screening. What I mean by that is if predictive modeling or machine learning could develop like an algorithm for an electronic medical record in which when the provider logs into that patient's chart, a best practice alert is what we call it, pops up and says, this patient may be at risk for food insecurity, further research is needed, or assessment is needed. We already have these for some indicators like cardiovascular risk, where EPIC is our EMR, and it just kind of pulls up that this patient is at risk and you may want to consider it. So that could be an important step forward. And finally, thank you all. This would not have been possible without so many different individuals, many of those in the room, SLU, WashU, and my family, especially my husband. That concludes my formal presentation. Okay, thank you.
Thank you for
Thank you.
presentation.
Well, just a comment that really thought you did a nice job setting it up for us, and then you even, with the implications and the theory, like, that was present throughout your presentation, which I think really strengthens the overall presentation. So it was a really nice job. I really appreciated how you brought us back to the theory with your, remember, this is where I got these variables, this is why, and then even just, this is important to clinicians, this is, like, that was just really nicely done.
Thank you. As we've always discussed, I think that connection from research to practice was the reason I joined this program.
Yeah. I do have a question, but
Yeah.
well, my question's kind of obscure. I mean, I was really interested in, it's not more of a question more than a comment, but I'm glad you're talking about the cancer types, because and even in your discussion, you talked about the cancers that have the most prevalence, but I was really struck by that table in your full dissertation where you had it all split up by cancer type. Specifically the cervical cancer. I mean, it was like in the in your discussion you talk about, well, these are the highest prevalence rates, but like breast cancer, there's a ton of people with breast cancer. So it really isn't shocking that a large percentage, like that is not much of a story. But with the cervical cancer, it was like 9% or 8% of the overall sample had cervical cancer, and then it was like 21% of cervical cancer patients have, and like, that's more of a story. And I was really struck by that. So I'm glad you're saying that we should look at that. And then even with the, and maybe it's, you had more female, right?
Yeah, and actually, I'll comment on that based upon existing research too. But
yeah, it was just really striking to me. And then I just feel like you should differentiate that. Like, you can't say the same thing between breast and cervical cancer when there's clearly something else happening there. Maybe it's ages you talked about, right? Maybe people are young. I don't know. There's something else happening.
Yeah, it's interesting. I didn't reference it, but there are two studies that look specifically, one at breast cancer and one at gynecological cancers, and they recruited from a gyne treatment center, and there were higher rates of food insecurity, I think comparable to what I found in my sample, that were observed in those groups too. So I definitely think it deserves further attention.
Well, because the breast cancer, it was about the same as what it was of the general population. So that to me was less, okay, yes, it's important. But the cervical cancer, there was such a jump. I just thought it was really interesting and thought maybe you could comment further on that. But
it's consistent with existing research, but I do think so. It depends. Some GYN cancers are diagnosed at a younger age. Of course, I don't know the exact prevalence of our average age of diagnosis off the top of my head, but then we also do see it a lot in the older population, so it would be interesting to look.
Well, and the other thing I noticed was your, even though on both the cancer food insecure group and the overall cancer diagnoses, obviously it's without kids in the home, there's also a jump related to kids in the home at the food insecure group, which makes sense, supports, but anyways, those jumped out to me as interesting points. Overall, I mean, I really don't have any specific questions. I think you did a really great job, and I enjoyed it.
Well, thank you for your support.
Torie, could you please bring Mike back? That way that we can see Mike as well. So, okay.
Oh, there he is.
Thank you.
Oh, we got Lei from China on here too. Joining us literally from China. Oh, Mike.
Hi, Torie. I thought you did a great job.
Oh, thank you.
Very happy as chair of the program. But I'm going to ask you some questions.
I would expect that.
So, and I think I may have asked you this at the oral exam. So, just excuse my COVID brain.
All excuses are there.
So, how sensitive might your results be by the coding of your dependent variable? So I think I asked you this before because kind of the measurement of food insecurity is kind of like, to be honest, I'm not sure what to make of it in terms of its validity, in terms of, like how do we arrive at whether a household is food insecure, not food insecure, on its way toward food insecurity, that kind of thing. And so, I mean, the dichotomization you probably have to do because you had like 174 people with cancer and food insecurity. So, but how sensitive would your results be to different coding schemes of the dependent variable?
I think that's a great question, and I think it's something that I should maybe elaborate on in my limitations section. I think definitely it could deserve more analysis at looking at seeing the overlap of those confidence intervals among those different groups and seeing how they would differ based upon those different levels and seeing if there are striking differences.
Yeah, the other thing is too, and I suspect the answer to my question is why would it matter? Why would I think it would matter? But in that data set, you pooled years 2015 through 2018, correct?
Correct.
So is there any reason to believe that survey year collection results are very different across any of those years? Like, for example, would your results be at all, would the pattern of results that you have be pretty much the same if you pulled out, let's say, 2016? Is there any unique years there where the prevalence or correlates might be a little bit different? And that's just a general design question of that survey. And by the way, I think it's probably pretty trivial. I probably shouldn't even be asking the question, but I just wanted you to think about it a little bit.
Yeah, I think it definitely warrants further consideration, and I don't have the answer specifically off the top of my head, but I can look into it.
Because you started off pooling right away.
Yeah. Yeah, I didn't. Yeah, that's exactly it. Because at my oral exam, I was planning on using 2019 data set, but because I wanted to look at that subsample, it didn't have a large enough sample size of cancer patients who were newly diagnosed. So I just started pulling in. I chose 4 years of data, essentially.
Yeah, understandable. The last question is like, so you sort of, in your theoretical model that you developed, it was informed by those other two conceptual models, correct?
Correct.
Okay, circle back now and think about your findings that you have, and how does it change the empirical status of your theoretical model that you developed? In other words, does that suggest that your theoretical model is supported or that it needs revision?
Great question. I think in terms of the adverse outcomes that was guided by Seligman and Schillinger model, it's supported. I think in terms of the coping strategies, it's somewhat supported. However, I think more work could be done on potentially flushing out that initial part that was about constrained resources and those trade-offs leading directly to food insecurity, and it may warrant more examination of what may or may not contribute to food insecurity risk and also what may buffer risk.
Right, so you would say that partial support, or from like a theory testing perspective, like if instead of the pragmatic results, now if you're just testing a theory here with your results, you would say that it's mostly supportive of these theories that you invoked. But how would your findings influence the next iteration of theory development?
A great point. Definitely will add, and I think it deserves more consideration of kind of flushing that.
It's a bit abstract.
Flushing that out more, yes.
I'm speaking at a little bit of an abstract level here.
It's okay, I'm pretty used to that.
I think to a great extent, both of your theoretical models are supported. Like thinking about advise the negative health outcomes. So majority of the negative health outcomes, you see a positive association with food insecurity. Now, in terms of the second theoretical model, when we think about resources limitation, coping strategy, and also buffering as mechanisms, you also have those positive supportive evidence, except of food stamp participation. But however, here we cannot say that the findings on food stamp participation does not support your theoretical prediction, mainly because you have this sample selection bias. Now, going back to Mike's great question about, okay, what do you add to this theory building and theory testing? I think we can come back to Carol's question about cancer type. So I think that's a very striking and interesting finding here, is that when we think about this unique population and think about their different cancer types, how we need to add that piece of information to think about how they kind of change these kind of mechanisms here. Definitely we see a lot of changes here.
Yeah.
So I think that might be one piece of your theoretical contribution. Like when we think about this particular population, we need to consider different cancer types and how that's going to moderate, interact with all of these theoretical mechanisms here.
Makes sense. Great. I appreciate your abstract discussion, Mike, and Gene's commentary.
Well, what's so challenging about it is you have a lot of things intertwined here,
Yeah.
and it's very rich and difficult to disentangle. And that's okay. I mean, it's just the way it is.
What is-
But you got to like a nexus, a confluence, so to speak, of very intersecting factors here, and it makes it interesting, but it is also challenging to try to drive a pathway of coherence through all of it and clarity.
What was your?
And-
I was going to say, from year one of the mini phrases that you taught us was, "Don't fall in love with your theory." So it seems like I need to be flexible in changing things based upon, future iterations of this study.
Well, that's true. I'm glad you remember that, because a lot of people do tend to fall in love with their theory, and they don't want to falsify it. They don't want to challenge it to be ever being wrong. They only want to prove it being right. And, that's the separation between science and ideology, of course. But, so I'm very happy to hear you say that.
I remember many of your phrases, and they are also translated to my work at the Healthy Mind Lab.
But no, overall, I'm just coming up with things to question you on, but I think really I'm very happy with the comprehensiveness here and really getting the most out of the data that you have here and telling a story around the findings. And it's obviously very important. So I'll let the next person speak.
Thanks for your comments and your support.
Guess it's up to me. I echo what everyone says. Very happy with your presentation, with your dissertation, and the creativity, the rigor of your analysis, and how well you wrote it as well. So you did. This is one of the easiest dissertations to read, which is I think one of the highest compliments. So
Thank you.
So what I'm going to say now is mostly aimed towards when you publish these. So and they're not necessarily criticisms, just things that might be helpful. I know you start dealing with power issues, because I would, like Mike, I was like, oh, she's setting up very low food security versus marginal. Some of her theory is about, hunger, and here it comes, and then it's not there. But I understand why. So I was looking for some ordinal regression, got logistic, and that's okay, but it was a little disappointing.
Future studies.
I think first of all, just drop snap.
What?
Drop snap.
Right.
Analysis when you go to publish this. And if someone gives you static about it, just say you ran it with it and it's the same. So
I'm getting really used to commentary to suggestions from reviewers.
yeah, so two overall things. First, they're kind of connected. I see poverty as the big elephant in the room. You know, like Mike said, you have all these, you know, confluence of everything, but really I think everything would be mediated by poverty. So that gets to the interesting thing about food is that, you know, think about when you're publishing this, what makes food different on top of poverty? And there's some ways we can talk about later about how you might do that, particularly if you're going to start, you know, looking at like prevalence studies. I think that, you know, how can you in the future really control for poverty, because that's the biggest thing that you need to, and not just control for it, but like really attend to it.
Okay.
Also, what is your, and the other thing with poverty and cancer is that it probably mediates that relationship too, right?
Yeah.
There's certain cancers that are more prevalent in people who have consistent poverty. So again, if you can control for that, you can zero that out. What is it about food insecurity and those relationships to cancer?
Yeah, that's a great point.
Right, so I think that would be that was my main sort of, you know, attend to that more than these other issues around race or gender or the other variables that you have. I guess this is a question particularly for the dissertation, specifically the dissertation. How valid is it to have 18-year-olds and 80-year-olds in the same data set?
Again, it's a great question. You know, there could be a lot of variation in age, and that may really have contributed. I mean, from a cancer standpoint, from that point of age 18, like, they're treated from an adult standpoint. However, there could be a lot of variation in that. And that's even like a topic that's being considered from like a treatment of cancer patients over time, and whether they were diagnosed in, you know, at age 16 and then all of a sudden they're 18, and how they're transition and looking at survivorship over the years. I think an opportunity for a future study may be limiting it to 18 to 64, and 64 to 84, and then 85 and above, and looking at it, those differences in food insecurity prevalence and these outcomes based upon those different age categories. So I think that may provide richer data, because you're right, a young adult cancer patient, from my own clinical experience, has a wealth of different needs and challenges in comparison to that older adult patient.
Well, particularly I thought one of the most fascinating outcomes was the assets. And so that's going to be very highly variable compared to a 22-year-old
Right.
versus someone who's in retirement, right?
Right.
And so just be careful when you're going to publish this, what the journal and the audience thinks is acceptable. I would think that and again, this is sort of a naive position, but looking at 60-year-olds, 65-year-olds and older cancer survivors, and then looking at their asset would be, a valid sort of, like, that makes sense to me. Looking at 20-year-olds with the 70-year-olds in terms of assets and cancer, that gets a little dicey.
Yeah,
So,
I agree.
but I understand it for a dissertation. Yeah.
Yeah, it's a good point, really, because assets, to me at least, are probably, to some extent, at least, developmental period sensitive.
Absolutely. I think I was trying to highlight that, especially saying when I said that, that younger age, they may not have been in the workforce as long as that time period to really accrue assets over time.
Jesse brings up an interesting point, though, I think, like what is the incremental validity of food insecurity among, like, if you just, for example, took out and analyzed all persons who are in poverty.
Yeah.
And, what proportion would be food insecure, not food insecure, and what does that matter? And that to me is kind of an important question, but or interesting question, I should say. Just even descriptively.
Yeah.
So related to that question is that one thing you can think about for your SNAP participation analysis, right? So you see, it's opposite of your prediction, theoretical prediction. We know because of the sample selection bias. So one direct implication of Jesse's comment and also Mike's comment here is that for that analysis, at least you could try another supplemental test to limit your sample to the households with income lower than 200% or maybe 100% poverty line. So that way, the majority of the sample in that analysis, they are kind of eligible for SNAP.
Right.
So then you are going to see, hey, for those eligible for SNAP but they do not participate, then in that kind of case, I guess you might still have sample selection bias, but it's going to be much lower.
Right.
Then you will see the coefficient in that new analysis with your original analysis. Definitely, you are going to see that coefficient reduce significantly.
Right.
In that
Yeah,
analysis.
I mean,
to support-
that's a means to reduce selection bias around that question. So it's an interesting tactic.
Absolutely.
But I mean, again, all of these are great comments. Like Mike's talking about the measurement level and also your theoretical contribution, ratio types, and also poverty and age. Those all are great questions. But I want to emphasize they are able to ask these questions based on your unique contribution and analysis results in this dissertation. As we know, previously there are not a lot of studies on this topic. So without those information in your dissertation, like it's very hard to quickly jump to these questions. So I think that's your unique contribution here. And I do not think those are meant to be kind of critiques of your dissertation.
No. I actually, it's making me think about all kinds of stuff. And so these are not revisions.
Okay, great. Oh, it's so rejuvenating. I love being in an environment where we can have this kind of dialogue. That's why I went to research.
Yeah,
And thank you for
I'm
this
not
compliment.
suggesting any revision.
Okay, great.
And I agree with Jesse that you have a great written dissertation, but I think your presentation is even better. Like you have all of theory building throughout the dissertation, and it's so clear. So I really appreciate that.
And like when you go to publish this, they probably won't care so much about your theoretical background, but it's so nice for a dissertation.
Really appreciate that.
And also the three ends kind of build supporting each other to present a whole picture on this new topic. So
You could probably publish that theory. Honestly, I think you probably could.
Well, thank you. I mean, potential opportunities are always great in thinking about how I can use this research. And just to comment on those slides, also, Mike, you taught us in theory to not put too many words on your slides. This was more of a challenge with this presentation, but I definitely did think about it throughout.
I like your grocery bag. You know,
Yeah,
like that's really.
The icons,
Yeah, I need some of that for
The
some of mine since I do insecurity.
they're straight the icons.
Awesome.
Yep.
Before I forget, one more minor technical comment is that also going back to Mike's comment about theory. So one inconsistent finding about the overall theory argument is that we actually have a lower food insecurity rate among this population compared to the general population, right? And you put a lot of efforts kind of trying to explain that. And we know like 95% of your sample, they are not racial minority and they are all old age people. So I was wondering if you can also kind of provide a better benchmark information for you to compare in the dissertation. So you say 95% of them are white, right? And maybe then if you can identify the specific food insecurity rate nationwide for our white or something like that, that's going to kind of align your results better to your theory. Otherwise, we will say, hey, how this population is even going to have a lower food insecurity rate compared to the national level. So see if you can find other better rational reference points for you to build these comparison.
Absolutely.
Yeah, actually, I was just looking as you were presenting because I was thinking the same thing as Jean, and just going by poverty rate, like USDA household characteristics, under 1% of the federal poverty line, it's about 35% households are food insecure. If you just do that for cancer patients or cancer survivors, basically at or below the poverty line, you might see a big difference. You might see a greater rate than 35%. Even if you find something lower than that, then that's interesting as well. So I think either way you cut it, you've got things that people will be interested in reading in terms of an empirical research article.
Great, it's exciting to hear.